Hey, I'm Dr. Tom Recor. I'm the DMH Forensic Liaison for the Mississippi Department of Mental Health, and I'm going to be talking today a little bit about who we treat on forensic services. The first group we treat are incompetent defendants, and so what that means is an individual has been charged with a felony offense and has been evaluated by a licensed psychologist or psychiatrist in Mississippi and been determined to not be able to work with their lawyer to prepare a defense. We accept those patients on order from a court and treat them for the purpose of being restored to competence so that they can face their charges. We do that by way of medications and individual treatment, and that can happen on both our maximum and medium security unit out here at Mississippi State Hospital at Whitfield. We also have two other groups of more long-term patients, and that's the NGRI acquittees, so individuals who have been found insane at the time of an alleged offense because they didn't know the nature, quality, or wrongfulness of their actions as a result of suffering from a serious mental illness. And then the not restorable high-risk individuals. And what we're talking about here is, as I mentioned, with pretrial folks, people who are charged with a felony offense, and no matter what we do, medications, treatment, etc., they are not restored to competence to proceed legally. We have to think about how to distinguish between who's high risk among them and who's probably lower risk and can be treated in the community as usual, and we'll speak to that endeavor as well. Three things we value that we hold high in value here at State Hospital, especially in forensic services. Number one, safety for the patients, safety for the staff, safety for the patients against patients, and patients against staff, and all of that. So sometimes folks that are referred to us have a history of violent behavior, and these are things that we have to consider in our approach to patient care. One of the other things absolutely is economy. I recognize that we take taxpayers' money to perform these actions in forensic services, and so we have to be good stewards of that at all times, and that remains paramount in our approach here. And the last thing is conscientiousness. Those of us in the mental health profession recognize that our calling is to do what's right for folks, and although that can be a challenge when someone's behavior is objectionable, we pursue that seriously, and so all three of these things we consider as part of an individual's treatment and treatment location. Bringing this slide up is simply meant to point out what we mean by high risk. So we talked about these other two groups, the pretrial incompetent defendants and insanity acquittees. What I mean by high risk are individuals who have, based on the available information, demonstrated a history of engaging in behaviors that violate the rights of others. And so what I mean is things like murder, predatory sexual behavior, arson, assault with a deadly weapon, these types of things that we see emerge in the community, that we want to keep communities safe from in the safety arm of what it is we do. These folks are people that we're going to retain and treat for a reasonable amount of time so that they're not back out too soon and we have bad outcomes. One thing I'd like just to point out is I've said here this definition is accurate, not precise. What I mean by that is a high-risk individual, just because a person is charged with arson does not mean they're high risk. You could think of a situation where a person falls asleep at a campfire after using an illicit substance and then it burns down the neighbor's trailer. That person who's unrestorable, although these behaviors are problematic, certainly this is not a person that we would consider unrestorable, high risk as compared to some of these other things. So murder, predatory sexual behavior, arson, assault with a deadly weapon, all of these things. So just because a person has a charge, I want to point out, does not necessarily make them high risk, although murder, predatory sexual behavior, arson, assault with a deadly weapon, all of those things suggest some probability that the individual is higher risk. This is a map of forensic services in Mississippi. I think this map is helpful to illustrate exactly how people come into the forensic mental health system. So you can see here that folks come in after an alleged offense. This is meant to represent an alleged offense. Folks come in after an alleged offense for a competency evaluation done in the community. If they're competent, they can be adjudicated. If they're not competent, they become a pretrial competence restoration patient. They're treated here. Once they're restored to competence, they can be adjudicated. So the first group of folks we're talking about are pretrial competence restoration folks. If someone at the time of the alleged offense was so impaired by mental illness that they didn't know what they were doing or that what they were doing was wrong, they can be found not guilty by reason of insanity, and they would be sent to forensic continued treatment service. So we've talked about two groups: pretrial competence restoration, not guilty by reason of insanity. Notice that this is an adjudication. You have to be competent to be found insane. And then the third group are not competent, not restorable folks whose clinical factors and charges make them high risk, probably higher risk. You see that? I say probably because mental health professionals are notoriously bad at predicting outcomes. And then I'm going to remove my image here. You can see that probably lower risk folks can go to civil commitment and community care as usual. So this is the map of how folks become one of those three groups. So pretrial competence restoration, not guilty by reason of insanity, or not competent, not restorable, and high risk. That's how individuals become a forensic services patient in Mississippi. One thing that is worth considering as we look at forensic mental health services and using scarce resources in Mississippi is how we use our civil commitment service in cases like this. There are cases where people have already been waiting in jail for a long time after being accused of an alleged offense, and sometimes the alleged offense itself is not particularly heinous, possessing some amount of a controlled substance or wandering into the neighbor's shed and stealing an old microwave. It's an example I commonly use. And especially in these cases, we want to consider whether it's most appropriate to refer that person to competence restoration or what we really want, which is commitment and treatment in the community. And I do not mean to presuppose that I have any sense of who that should be, but something that I want to point out as a possibility is in these cases where folks are less threatening and could be possibly treated in the community, there is a way to remand charges and have folks civilly committed with an outpatient commitment and still be able to keep an eye on how they're doing and get them where they need to go quickly. And this slide is meant to just illustrate that. Okay, I've removed my image from this slide to point out a few things that I think are fundamental to how we approach the things we've been talking about. You can see the three groups up here: pretrial folks, NGRI folks, and the high risk, not competent, not restorable folks. At some point in their stay will often need maximum security, but very often can be safely housed on medium security units. And for that matter, we often bring people who could be admitted to max if they seem to be doing well on their arrival, or even based on information we get from the jail, we'll bring them into the medium security unit right away. Looking at the forensic services CTS patients, this is how those folks move through the system. So you can imagine that a high risk, not competent, not restorable person would go from maximum to medium, and then we have something called a transfer advisory panel, which is a group of clinicians with forensic training and background whose role it is to look at the risk factors and be sure that a person is ready to go to a medium or minimum security unit, still inpatient. So we've got this stratification as folks are doing better and better. They're moving continuously supervised through this system and then can land on this medium minimum security unit. Now from that point, you can see that I've highlighted here that these moves require notice or permission, and that's just to point out that for a not competent, not restorable person, we have a requirement to notify the DA if we're going to let them return to the community. And for a not guilty by reason of insanity person, we're required to ask the judge for permission, and the judge can issue an order allowing folks to live in the community under some kind of supervision or live in an on-campus apartment at one of our facilities or off-campus apartment with continuous supervision. And frankly, we appreciate this level of collaboration because it's truly fundamental to this process of keeping communities safe and understanding what the relevant issues are. And so to the extent that the Department of Mental Health hasn't gotten this exactly right in the past, this continuum allows us to do things in the way that we've sought to do them for some time now. And this is the last slide I'll speak to today. All I mean to do here is to point out that sometimes folks have to come back. And a properly designed system recognizes that folks will return to the community, and if they're having a hard time before we start to see bad outcomes, we can bring them on back, and that just speaks to the need for continuous supervision once someone has demonstrated that they're ready to go to a lower level of care. This continuous supervision is fundamental to us being successful with this model. That's all I've got for today. I appreciate your attention and thank you for your time.